session on designs, I thought we will do a real recap, which is to really check your knowledge. Okay? So I will show you a design and ask you to identify it. And maybe I will call out the country and the country can answer. Is that fine? Or does anybody else have a suggestion? Okay. Before I get into the examples, I want you to tell me what was a broad classification of research designs. Broadly, IR designs are classified as? Oh dear. Okay. Donnie took the class, I think, right? Maybe, okay. Does that ring a bell? Do you remember seeing that slide? Okay, that was an introduction to study designs. That's the question I asked you. Broadly, they are divided into intervention and non-intervention studies. Okay, very broadly. Yeah, that's the two.
Observational.
Yeah, non-intervention, that is when you are not doing anything. And intervention. These are the two broad classification of all IR studies. Okay, does that look familiar? Yes? So when we are just describing implementation process, barriers, we are not doing anything. We are not intervening, right? We are not doing an experiment. These are non-intervention studies, descriptive studies. They could either be qualitative or they could be cross-sectional. Yes? Qualitative meaning you're talking to people and getting information about barriers and processes, or you are doing a survey wherein you are collecting quantitative information, and those are two examples of non-intervention descriptive studies. You could also have non-intervention analytical studies. Now the difference between just describing it and the analytic part is that you are trying to look at the causal pathway, but in these studies you cannot make it is only associations. You cannot make a comment on causality. Okay, all with me? You cannot say that it's because of my intervention that this happened in a design of this sort. Or because of a particular, say for example, tobacco taxes were introduced in 1999. Smoking rates have decreased. I look at it as a trend over a cohort maybe, but I cannot say it's because of the tobacco tax that smoking has decreased. All I can say is maybe it is related. So those are the designs where you're doing analysis to see why something may have happened, but you cannot establish causality. So in that sense, these are non-intervention analytical studies. Two major designs are the cohort design, wherein you follow up a group of people over a long period of time. That's your cohort. Or you do a cross-sectional survey at one point in time. Yes? So these are two main designs here. And then, of course, you have your intervention studies. And under intervention, these are the four most common ones, but there are many others. You have the quasi-experiment, a pragmatic trial, a step-wedged randomized trial, and an adaptive trial design. Okay, and now is the quiz. Okay, if you can quickly read that. Is it visible to all? Okay, focusing on the parts that I have circled. And then I will ask some team to please tell me what is the design. Okay, so maybe Tunisia can tell me what is the design. Tell me the broad classification and then tell me which under that. Yeah, sure, take your time, no problem.
It's a cross-sectional.
What broad classification would you put this under?
Non-interventional.
So non-intervention. And then, is it analytic or descriptive?
It's descriptive.
It is descriptive. And then it is a cross-sectional. Okay, everybody agrees? It's a non-intervention, descriptive, cross-sectional study. I also agree. Okay, we'll do one more. That was the title of the study, and that's why I didn't show it, because it has the name in it. All right. Okay, maybe the Philippines can tell us after you've read it. Yeah, go ahead.
It's non-interventional.
Okay, great. It's non-intervention.
It's descriptive.
Do you think it's still descriptive? So just to say it again, basically they're looking at WHO surgical safety checklist, which was implemented at a certain point in time, and then they wanted to know whether complications have decreased or not. So it's non-intervention for sure. Is it descriptive or analytical?
Step which?
No. Okay, first let's look at whether you think it's an intervention or a non-intervention study. They are trying to see, so there was an intervention, I agree. It's an implementation of a intervention for trauma in schools. And they are trying to explore factors that have influenced implementation. Okay, so they're two different things. And how they did it was by telephone interviews. So that's all you need to focus on in the method. How many of you still think that they are evaluating an intervention? Is this about the intervention? Yes. They're talking about factors that are influencing the implementation. So it would still be in the non-intervention category. We don't know whether the same group is the one that did the implementation, or whether this is a program that was done by schools and they are now looking at factors affecting the intervention. So it's non-intervention. Is it descriptive or analytical? It's descriptive. It's describing factors. Yeah? So that's clear. So it's a non-intervention, descriptive, using cross-sectional survey design. Okay, all of you are looking very confused. Any doubts? Context, you would have need to do. I agree, but if this much about the method, the rest of the examples are also based on very limited method. But just focusing on the method, you can tell whether it's an intervention or a non-intervention study. Yes? Okay, maybe I just go back to the classification once more. So that's how you break it down for yourselves. You first see whether this is an intervention, non-intervention. If it's non-intervention, you look at, are they describing implementation process and barriers? Are they looking at a cause and effect? If they are looking only at describing processes and barriers, they are descriptive, right? And that could either be a qualitative study or it could be a cross-sectional study. So when you think of your questions, you need to think of it in this way. Am I doing an intervention? Am I not doing an intervention? If I'm not doing an intervention and I'm in the non-intervention category, am I trying to analyze and look for cause? Or am I trying to only look at barriers and facilitators? If I'm only trying to look at barriers and facilitators, do I want to do qualitative interviews? Do I want to do a cross-sectional study? How do I want to collect? What kind of design would I use? So that's how you would use this classification to help you also think through the most appropriate design to answer your research questions. Yeah?
Sorry.
Yeah.
Can I ask for the last example?
Yeah.
So the CBITS itself is not intervention?
Yeah, it's an intervention for sure. But what they want to look at is only the barriers of this intervention. So it could be that schools were implementing the implementation, not them. And they are only now studying the barriers, and they are reporting to you only the barriers.
Sorry, maybe I'm a bit mixed from intervention and implementation strategies.
No, so say your confusion again. What is the confusion?
So from this example here, so it is interventions or the strategies. What does it mean by the non-intervention or intervention in the program? Is it the strategies itself in the implementation?
Great, good question. So she's asking, what exactly are you talking about when you say intervention, non-intervention? So what I mean, what the designs mean by intervention is when you are introducing a change. It could be an implementation strategy, it could be a new drug, it could be a new program, it could be anything. But you are introducing a change, right? So it was not there before. In your study, you are introducing the change. You are evaluating it for effectiveness. That is an intervention study. Does that make it clearer? Yeah? As opposed to, for example, implementation strategy, what kind of things would you include? In implementation strategy, what are you thinking of?
For example, like in our topics, the intervention is screening, and the strategy is to train.
Okay, so I wouldn't break it down like that. You can also call your whole thing an intervention, which is the introduction of a TB agent to do screening, and that is an intervention. Yeah. Okay. So it would be a combination of the strategy and the and what you're introducing.
Because in several book about IR, they differentiate between this is the health intervention and the intervention for the intervention itself is called strategies.
Okay, that can be confusing terminology.
Yeah.
When we say intervention here and we're talking about an overall design, we mean both things. The strategy you're going to use as well as the intervention that you're going to do. And very often there's an overlap.
Yeah.
For example, in the TB agent by himself, it doesn't make sense, right?
Yeah.
So it's the introduction of the TB agent for screening, which is your intervention.
Okay.
Yeah. It is DOTS therapy for TB, that is the intervention. So DOTS is both a strategy as well as the intervention. Yeah, I hope that makes it a little clearer.
Thank you.
Yeah. Okay. So, and then the next category is about the intervention studies. This is the steps. I wanted to now look at effectiveness of the DOTS. DOTS, all of you are familiar with, the directly observed treatment short course for tuberculosis, okay? Which means every single dose is supervised. What I did is I took lots of patients with TB at a tertiary health center. I said I will take only between 30 to 60 years of age because I did not want extremes of age. I did not want to look at children because that's another complete different set of regimes and treatments. I only wanted adults between 30 to 60 years with no comorbidities, so I don't want people with diabetes complicating, I don't want people with other kind of infectious diseases complicating because the regime drugs might change. So I want only people with no comorbidities. Also, compliance may be an issue because they will have to come to the health center to take the medicines. So I fix a 5-kilometer radius and I say people only living within that radius. Then I randomize them into 2 groups. And then I give DOTS to one, and I give standard treatment, which is not supervised. I give them a prescription and tell them to buy their medicines. And I'm looking for effectiveness or cure rate at the end of the study. What do you think is the design of the study? Okay, so Maria thinks it's a randomized controlled trial. Anybody else? Okay, why do we say it's a randomized control trial? If everybody is agreeing, then everyone tell me reasons why you are agreeing. Okay, one reason, Ghana, why is it a randomized control trial? One reason. There are many, but one, you tell me one. Okay. Is that enough to say randomized control trial, or what is important there? I'm looking to say, how will you say that this is a randomized control trial? Or why are you agreeing that it's a randomized control trial? So some method is being used to randomly allocate people into 2 different groups. One will serve as the intervention, one will serve as the control. Very good. Philippines, one more reason why this is a randomized control trial. You agree it's an RCT? Yeah, why do you agree? From the information given. Any other reason?
Can I?
Okay.
Inclusion criteria.
Yes, very strict inclusion criteria. Okay, I'm specifying what group of people I'm going to study. So, extremely strict inclusion criteria. Very good. What else? The outcome ultimately, I want to check effectiveness. So, that also tells me that this is a. So, you remember this table? It was there in the online. If I do randomization, so randomization, yes. If I'm testing the intervention works under ideal circumstances, it's being conducted in a controlled setting. Comparator could be a placebo, but placebo is ethically not allowed in this case. Therefore, I'm using it against standard care. There's a fixed protocol-driven regime. And my goal is to check for internal validity. So I'm not still talking about generalizability. I'm just saying, does this work in this group of patients? Right? And these are the reasons why it is a RCT, like you all correctly identified. Okay, I'll give you one more setting. Now I want to determine effectiveness of DOTS through primary health centers in rural India compared to standard treatment that is non-supervised. I want to include patients all who have been diagnosed in the community. I randomize the group of PHCs who will deliver DOTS, and I take another group who will deliver standard treatment. And I also realize that because there are different age groups, I will have to tailor the regime to the different age groups. What kind of a trial am I? So these are all intervention studies, agreed? A primary health center. What kind of a design am I talking about?
Pragmatic trial.
Huh?
Pragmatic
A pragmatic trial. Okay. Why do you say? Does everybody agree it's a pragmatic trial? No. Okay. What do you think it is? All right. Sorry. The randomization is cluster randomized. I agree. But overall, the name of the trial would be a pragmatic trial. Yeah. Or a cluster randomized trial.
So in what case would it also be? Maybe after you have explained why it is quasi.
Yeah, we'll come to that. That's the third example. All right. So why is this cluster pragmatic trial?
Because it is RCTs in the real life setting.
Okay, very simply put. But can you break it down? It's a randomized trial still, because you're doing randomization.
Yeah, but
right?
no.
You're allocating randomly to two groups. Okay, so that's there. So that's clear that it's a randomized trial still. It's including everybody. So do I have a strict inclusion criteria? No, it's a very general inclusion criteria to mirror real life setting as much as possible. Treatment regimes are flexible, patient oriented. And my goal is now to see, can this be run in other facilities also? So external validity is what I'm trying to look for. I'm not looking at, is this treatment regime good? I'm looking to see now, can this be taken out to the different primary health centers in the country? Yeah? Why are all of you looking so worried? It's worrying me. It's not that difficult.
I think it's because sometimes there are overlaps in the descriptions that we give in terms of exactly what we are looking out for to categorize.
I may actually be using a placebo, but I'm doing it in the real world circumstance. So then where do I fit this in? Is it RCT or is this a pragmatic trial? I agree. But even then, when you design, you should think of which category it fits into and try to keep it as close to the definitions as possible. Of course, there will be deviations, and I take that point well.
I also think, because in the online course, and that was one of my comments that I will be saying later, but this course, for many of us, it's the first time that we hear, except for RCT. Like, we don't know pragmatic trial.
Oh yes, but that's not expected of you to know.
Yes, but in the online course, the table was with all the types and without examples.
All right.
So that's why.
Yeah. We can feed in more examples, but we really, pragmatic trial, adaptive trials, these are all new terms for all of us when we got into IR. So we are not expected to know it. But if you found it difficult, then yes, we need to integrate more examples, and we take that. Yeah. Okay, then one more example. So now I want to compare outcomes of the DOTS therapy in a district which is implementing the national program. So it's already part of national program. and I want to compare it with a district in which there's no dots. It's still not included in the national program. Okay? So based on my previous 2 studies, government found dots very effective. They decided to include it in the national program, and therefore they started doing it in a phased manner. Some districts took it up, some districts are yet to take it up. So now I'm comparing outcomes in a district that took up the national program versus a district that did not take up the national program. What else?
Adaptive.
No. Quasi-experimental, yes. So why am I calling it a quasi-experimental? Step wedge we'll come to. You'll know clearly why a step wedge is a step wedge.
I see one not yet started. I think it will be started.
But that's an assumption you're making. I didn't tell you I will start it. If I had told you, then that design would have been correct. But I didn't tell you I'm going to start.
Not yet started. I thought it will be started soon or something.
Yeah. I suppose it would be started soon, but I won't be studying it then. So then it's not a step wedge. At the point of my study, it is clearly 2 groups. 2 groups are not randomized. Did I randomize them? No, it has just happened by default. And I am taking these 2 groups to represent experiment and control, right? But I have not done the randomization.
But why isn't that a cohort study? I'm just following 2 cohorts there. For example, I'm following cases in one setting.
Yeah, absolutely.
Following in another.
You can think of it as that, but it doesn't fit the definition of a cohort. So a cohort usually is one group of people that are followed up for a period of time. The control or the comparator is built into the same group. But the control is built into the cohort. Your control group comes from the cohort. Whereas here, one group is the control and one group is the intervention. So that's the difference. Okay? All right. So if we break it down, there was no randomization. And that is typical of a quasi-experimental study. I just choose 2 groups. It could be by, in this case, a natural experiment. It could be any 2 groups I pick, but I have not randomized. And that's the key difference between RCTs, pragmatic trials, and quasi-experimental. Okay? And I'm still looking at the goal being external validity, which means now can this be generalized to all of the country? Can it be scaled up or not? All right. One more. Now I want to compare the outcomes of DOTS therapy in a district with the national program compared to standard care, similar to what already we did. But I take 10 PHCs, primary health centers in a district. I give them DOTS, and there are 20 others which don't receive DOTS. After 1 year, I include another 10 into the experiment group and only 10 in the control group. So what am I doing? This is a clear step wedge design, right? So no confusion. And that's the diagram that was shown to you on the online phase. So what you're doing in a step wedge is in a phased manner, including the control group to become experiment, and then comparing it with the remaining who remain controls. What are the advantages of this design? Why would you use a design like this as opposed to just taking 2 groups? Ask, Kucha. We have problem here.
I'm confused. Can we go back to the previous slide?
Yes.
It says that after 1 year, 10 more PHC receive DOTS, and then continued 10 more continued. So it's not. So the time doesn't matter for the exchange. The time.
Time, as in 1 year or 6 months or 2 months.
Yeah.
That time. No, it doesn't matter. Why do you have a doubt?
The time and also the number of the PHC.
Also doesn't matter. It will be calculated based on a sample size of how many PHCs I need at any point in time to do the comparison, but that has got nothing to do with the design. Idea of a step wedge is I take few now and the rest are control. I take a few more now for experiment and the rest are control. So by the end of it, everybody is experiment. The time, the number, but the number is calculated. It's based on a sample size calculation. Yeah, it will be different for different studies, different outcomes.
But when you randomize the time when one becomes a control?
No. So the time is not randomized, but the groups are randomized.
Yes, but they are randomized based on when they will become another.
No. No. Time has nothing to do with randomization. How is time related to the process of randomization?
Because let's say that there are clause 1, 2, 3, 4, 5, right? So you have a time period.
Yes.
Oh, I'm just confused because my understanding of the stepwise design is, I don't know, it's different. So my understanding is that every group start this control, right?
Mm-hmm.
And then you assign randomly when, for example, then you have at the time period number 2, this one will become
Yes.
intervention.
Yes.
And then, but you have a random allocation of the time period when they will become.
So the time period is decided depending on the study, the question. The time period is decided. Allocation is random. So they're two different things. The time is not being randomly allocated.
Yes, yeah, I know that the time period is defined, right?
Yes.
So 6 months,
Yes,
11
or
months.
3 months, and depending on
Yeah,
the
but
question.
in the example, you don't have the random component.
Oh, very good. Okay.
So
I agree. So when I say 10 more districts were taken, it is randomly being allocated to that's correct. Okay. So I miss here mentioning randomization, but this entire design is a random design also. There is randomization built into the design. So the allocation, the selection of these next 10, is a randomized allocation. It is not by my choice, right? I cannot just say another 10. It's a randomized allocation. Yeah, thank you, Maria, for pointing that out. All right. And then this last one, where I start by, I want to compare.
Wanted to say why the step wedge design. You didn't explain that. I think they're all waiting for it.
No, I think they all got it. Somebody explain why is this a stepwise design.
Nobody. I didn't.
Okay, anybody want to volunteer why is this a stepwise design?
Why?
What I was expecting was the table.
Sorry. I asked why do we do this? Why this design? Thank you. I forgot about my own question. Yeah. Why wouldn't I just choose to do a randomized control trial? Why would I choose to do this?
Because one sample can be controlled for themselves. And for example, one group, they start not receiving anything, and by the time they receive the intervention, so themselves become control for themselves.
Okay, but then I could just choose a before and after design. Maria.
I think it's also because with this design you have the possibility to learn from the intervention, because you are not doing the intervention and non-intervention at the same time. So you can learn from the experience of the intervention in the first places and then apply those learnings to the second phase.
All right, so that's part of the pragmatism of these kind of trials, is you can apply, but you would be limited with what you can apply, because after all it's a trial. So I don't think we could make major changes, but small changes could be made. Any other bigger advantage?
Can I ask? Actually, I'm a bit confused to use this type of study and the adaptive one, because we by the time we make adjustment to the intervention, like in the adaptive, we also make adjustment for the each of groups. So actually, when we use this.
Yeah, that's a good question. So all diseases, all kind of conditions, all kind of questions will not be amenable to a stepwise design. Especially if time is playing a crucial role, then just extending it over various periods of time will change your findings completely. So all questions, you cannot use this. This is a very specific design for certain kind of questions. And it kind of best fits the national program kind of scenario. You know it's effective, you are phasing it into the country, you still want to look for effectiveness. This is the kind of design you will use. So it's not an obvious choice for all types. If that's your question, there are very specific questions that you would use this design for. But what's the biggest advantage again with this design? Why would I use this?
So I might be wrong, but I think you might want to use when it's an intervention that is likely to work, and then by the end of the trial, you want it to be implemented in
Very
all the
nice.
sites.
Yeah, so it's the ethical advantage is the biggest. The problem with doing a randomized control trial for, say, DOTS therapy, which is well known to have effectiveness, is that my ethics committee will say that you're depriving it to other areas. So then my answer is this design, where I say I'm not going to deprive them, I'll just delay it, which is somehow a little better. At end of 3 months, they are going to get the intervention, but I do need that control information to be able to really say whether it was effective or not. So the biggest advantage with this, and when it's used most also, is with programs where they are likely to be effective and that you are looking at it in a phased manner.
Yeah, I was going to say the table that you had for the other ones, yes. Really helpful, because I was just thinking through what the comparator will be, at what point, would you consider the advantages of the different comparators? Yeah.
So it would fit some of this. You could use this similar kind of a box to also describe your step wedge design, but I think the design could not be captured with the headings given. That's why I dealt with it separately. It's a very unique kind of design. Yeah. Okay, and then the last one is this one. So I wanted to compare DOTS with standard care. I'm not very sure how good it is. So I give it to only 100 patients. I have written 100 there. There would be a sample size calculation. Assuming it's a small number, I only want to really check whether this therapy is good or not. And then I found that it is good. So I wanted to take it out to try it in the real life setting. So I tried it out at 5 PHCs. I may also in a certain group find that it did not work. If it did not work, I still want to work with the regime, but I tweak it a little bit. I change the drugs probably, dosages, I adjust all that, and again test it. I might find it beneficial at a certain regime, a certain thing may be beneficial, a certain may not. So with this flexibility of being able to work with both null findings as well as beneficial findings, if I do a trial, at each of these stages there is randomization. So that is what is characterizing this as a trial. But this kind of a design is a adaptive trial design. So we did this. This is the picture that they showed you. It's a typical adaptive trial design. So based on the findings, the next step of the design of the trial is decided. That's the key message. But like I said, this may not be amenable to all questions. There are very specific kind of questions for which you would use this design. Yeah, Maria.
I just wanted to highlight that it is also in the protocol, so it's not like if I don't find anything, then I change. But there are points that are strictly defined when I'm going to measure, and that's also very important in this design.
So that's important. This adaptive trial design is a design. So you've already designed it beforehand, specified your time periods, specified what you are going to do if you find it beneficial, if you find a null finding, and you will move as per your protocol. It's not completely arbitrarily left up to you to decide at that point. Yeah, totally. All right.
Cost and time.
Very good. Resources, cost, time. Okay, randomized control trials are expensive to do. Other considerations? Okay, so that was the slide that was shown to you in the online phase. Well, how much is known about the problem, what your objectives are, what the available resources are, and your own ingenuity and creativity will decide which type of design you choose to work with. Also depends on so of course the question is what is dictating it, yeah? Whether you're looking at can something work, whether you're looking at does something work, will it work? So based on your research question and how you frame it, your design will also differ. Okay, and then, so the design is clear, selection of study design is clear, it's all based on your research question, it's based on your resources, it's based on ethical issues, and that's how you decide a study design. Once you've decided the design, so I decided to do a randomized control trial. Now whether I will use quantitative methods or qualitative methods, what does this depend on? Yeah, it depends on the data you want to obtain. So do you want to obtain quantitative data or do you want to obtain qualitative data to answer your research question? What else does it depend on?
the design?
It depends to some extent on the design, yes, which depends on your research question. Agreed. What else does it depend on? Absolutely. Yeah. So the question and how you frame it. What else? Do you influence the choice of your method? All right. Okay, capacity is one thing. Other than that, what am I driving at? It was dealt with in the online session. So Donnie spoke about research paradigms. Yes? Research paradigms are how you view the world and therefore how do you view a particular question. Right? And it comes from research disciplines, and he spoke briefly about that also. So the same question of how are patients satisfied with care for diabetes, if I show that question to somebody with a social science anthropology background, they may instantly want to only do qualitative interviews. If I show it to somebody with a positivist background or a more study design, more epidemiological background, they will immediately talk about quality of life scores. They will talk about putting it into a number, quantifying it, measuring it. And why is that difference there? It's the same question. Difference is because of the researcher and our paradigms. So I may look at everything in a very quantifiable manner, and that's my paradigm. I'm a positivist. Or I may look at it as a very social science paradigm, which is the constructivist paradigm, which is where everything has multiple realities, everybody's world views are different, everything has to be taken into account to make sense of the research question. So paradigm also matters on what you choose to use as your method. Agreed? Yes. Do you all know which paradigm you are from? Yeah? Maria is nodding her head very vigorously. She's absolutely sure. Very uncomfortable. Yeah?
Just asking, in terms of paradigm, let's assume that you've identified your design, an RCT. Where would paradigm then come in?
Yeah, very good question. You've designed your RCT, but how are you going to collect your information? Are you going to measure it? Are you going to interview and then assess effectiveness? So your outcome measures, it could be a trial design, but how I have defined my measure depends upon my paradigm. And that's where the use of either qualitative or quantitative data comes in. Do I make sense? But I also agree that mostly an RCT will be chosen by somebody from the positivist paradigm. It's very rare that a constructivist will choose an RCT to look at their outcomes because they're not amenable to the complete RCT design. I agree. But having said that, somebody may still choose qualitative methods to look at effectiveness and not quantify it. And that would be from the constructivist paradigm. But still design it as a trial. Yeah.
But also you can have some other studies within the trial, right? So you can also have, for example, the big trial where you want to measure something very quantitative, but you can, inside of the trial, make qualitative studies. So, of course, I don't think it will be made by the same person, but one thing doesn't exclude the other. You can still do some things inside of the
All
trial.
Right. Very interesting point Maria has raised. So there are two ways you can do what she's just said. That is, I can think of a question to ask within an ongoing trial, or my trial itself is choosing to answer both questions. Okay, so do you understand the difference? The trial is going on, an anthropologist came and said, oh, this is interesting to look at, let me look at this. One thing. Or when I started the trial, I wanted to know or answer both questions. So I brought an anthropologist when I was designing the trial, and in my second scenario, what kind of method would you call that? What methods have they used? Yes, that is a classical use of a mixed method. And that is when you would use mixed methods, when you want to answer both kinds of questions. Coming back to paradigm, how does a mixed methods reconcile different paradigms?
So I was going there that there is also the pragmatist.
Very nice.
Which allows us to combine it. So when we start with the positivist and the constructivist, it's as if there is no room for combination.
Very nice.
But there is.
Yeah, so it's the pragmatic position. There's a outside position called pragmatism, where they say the research question is king. They can shift between paradigms. You just need whatever information you need to answer the question best. And that's the position from where you can mix methods. Okay? Otherwise, the paradigms are different. But you can mix methods, like Phyllis said. When would you choose to mix methods? Is mixed methods common in IR? Very common in IR, because most often we are at that pragmatic position where we're trying to answer practical everyday problems, which don't have a quantifiable one answer, and they usually have a qualitative aspect of the why did this happen, how did it happen, and you want to know that also. So in IR, it is very common to have mixed methods as a study design. Okay, when would you use mixed methods as a study design? Okay, I think you did some of these again in the online. Either you want to get different ways of answering the same question to really know that you've got an authentic answer to the question. Okay, so you want to do triangulation and then you would like to mix methods. You may want to elaborate results of one by another part of the study. So for example, in Phyllis's study, they want to first do the systematic review, they want to do interviews. Based on that, they will do the next phase, which is to design the interventions. So you may want to then mix methods. This is also similar when one is informing the development of the other. Or, you found something that is not fitting in, and now you want another method to kind of understand this phenomena better. So I thought this intervention was very effective, but actually it wasn't working. I need something to explain it. I will use qualitative methods to understand it better. So that's another reason why I would mix methods. All right, all of you are looking extremely exhausted, but I hope it was interesting and helped you to recap some of the designs. Okay? Right, I'm not going into the details of how do you do quantitative, qualitative. That's been dealt with in the GHRP as well as in the online phase of this. But you can always look at that video. It's Donnie's gone exhaustively through different methods that you can use in each of these methods. Okay, I'm done. If there are any questions.
We can take 1 full hour because we only save time and we
Yeah.
No pressure. 1 whole hour. Just forget about this and
Enjoy your lunch after this. I know, they're all looking exhausted. Come back and try to do the baby shark dance. Yeah. Okay. But if you have questions in your mind, please do come back and ask.
Some fun exercise after the lunch. Okay, ready? Yeah. Okay. 3, 2, 1, go! Ping pong!
Daddy shark, do-do-do-do-do, Daddy shark, do-do-do-do-do, Daddy shark.
Grandma shark, do-do-do-do-do, Grandma shark, do-do-do-do-do, Grandma shark, do-do-do-do-do, Grandma shark.
Grandpa shark, do-do-do-do-do, Grandpa shark, do-do-do-do-do, Grandpa shark, do-do-do-do-do, Grandpa shark. Let's go hunt, do-do-do-do-do, let's go hunt, do-do-do-do-do, let's go hunt, do-do-do-do-do, let's go hunt.
Run away, do-do-do-do-do, run away, do-do-do-do-do, run away, do-do-do-do-do, run away. Safe at last, do-do-do-do-do, safe at last, do-do-do-do-do, safe at last, do-do-do-do-do, safe at last. It's the end, do-do-do-do-do, it's the end, do-do-do-do-do, it's the end, do-do-do-do-do, it's the end.
Okay. So now we are in the exercise 2. Yeah, exercise 2. We have 1 hour exercise. You can continue in your group discussing the study design methods and data collection tool for 1 hour. The presentation will be 4. Yeah. Oh, sorry. There should be the exercise again at 4. So the presentation will be tomorrow morning. Yeah. Okay. Okay. Thank you very much.
Everybody is still very busy with the exercise. I hope it's... Shall we start with the recap? And then you can continue with that, because... and I think I can be shorter than the allocated time, because I know that most of you already have a lot of experience with building team. As senior researchers and with many experience of research. But just a quick question. And why this team building is very important for IR? What do you think? I don't know in other research method that we spend quite some time to discuss about developing a research team than in IR, right? So what do you think that it matters?
I will say that because one of the key characteristics of implementation research is the multidisciplinary between the participants, and I will say not only multidisciplinary but also multi-sector, public, and academia, and
yeah. So because it's as one of the main characteristic of IR is this multidisciplinary, multi-sectoral collaborations, so that it's matter. Why? Because each discipline, each profession, they have their own culture, they have their own understanding, implementation research project, because otherwise, if you don't have some understanding and function as a team, then you might not have a good IR implementation in the field. So if we see in the toolkit, this is a step where when we have a project and we want the project to have a good sustainability, it should be start with a good research team. And therefore, team building is critical for that. Because with team building, we can create dialogue. And in IR, as you mentioned, that the research team is not only one sector, one profession, but also multi-sectoral. Even with the beneficiaries, we might have a team for that. So with that, we can create dialogues, and with the dialogue and engagement, we can have ownership of the project, right? And when they have ownership, it creates a bigger uptake of the project, and it leads to sustainability. So therefore, a good research team is very useful and very critical. But if we want to have a functioning IR team, what do you think is the typical members of IR research team in your experience. I think you already mentioned in several in the themes. Phyllis.
So I'm thinking that it will be key to have the implementers there.
Implementers,
yeah,
yes.
exactly, yeah.
For sure. Can you be more specific about that? Others to elaborate? Maria?
So to elaborate on what Phyllis said on involving the implementers is that it was said that questions should rise from them.
Mm-hmm.
So that means there should be for example, in our case, it's the Leishmaniasis program, right? So then it means that we need to have the nurse in charge of the program, or the community health workers who are administering the drug, and then nurses on the facilities who are also doing that.
And also to add to that, because lots of the times you want the information to feed back into the delivery processes, like your findings to inform the changes. So they need to be part of it so they understand that you went through this method. When you are bringing the findings, then they are open to receive the findings from you.
Yeah. What other research team you think we need in IR? What kind of professional background that we need? I think we already touched some of that yesterday, because when we talk about your research team, you mentioned that I need this, I need that for this thing, for that. So, Wafa, you're looking at me.
In our case, we must have epidemiologists, clinical trial,
clinical trial, epidemiologist with clinical trial background. Okay.
What else? Healthcare.
It depends on the question and the work. So we
certainly.
don't know.
Depend on the question, yes. But another thing that also, I think we also discussed yesterday in IR, that it's also fit to the program, and there's a dissemination and communication. So we also need someone with communication skills, expert in communication and others. So this is not exhaustive list, but usually we have the scientist and then different type of discipline depending on the research questions, but also usually we need this media and communication specialists, and big part of the implementation research is monitoring and evaluation. So those expertise should be also one part of the IR team. And
Donnie?
Yes?
And I also will say
Please.
that a qualitative perspective is very important in IR, especially because the mixed methods is very common. So we already are challenging some needs about people with qualitative background.
Yeah.
So I think it's key.
At least social science background, because it's when you need to engage the community, then that's the skill that we really need in the IR. Any other comment on that, Dorothy? No. Okay. So when we talk about building team and we see those steps, it's in the during the first step of IR cycle, and this is in the when we try to also contextualizing the studies. So that's part of we understand the concept of the problem where we are, and then what are the stakeholders, who are the stakeholders, what are their roles and everything, and that's something that we map, and then we will see who should be in our teams, who should be our collaborators, and then we have some these activities, team building, and together because as you mentioned that the IR problem should be from the program driven. So it should be within that we set priorities, and also we need to define the capacity caps, because then also in your exercise there's a where we try to see in the IR exercise there's a capacity development plan. So here that we have to do when developing IR team. So we map the stakeholders, and then we convene, then we have a brainstorming, productive dialogue, and then setting priorities, and have a capacity strengthening plan. Okay. So why do we need this? Because understanding the opportunities and challenges in existing research partnership, we want to know, again, within the contextualizing, who is stakeholders, what are the capacity, how can they contribute to the project, whether there be conflicting interest and this kind of thing. And then we can have gather information, and also consult with relevant stakeholder, and also identifying even resources, right? So if we discuss, and then we, some stakeholders, they have networks, and then when we gather information, we also understand and knows what are the resources available that we can use for our project. And another important thing when we develop teams is that these principles, to have a productive dialogue, also we set up in this workshop that it should be have inclusive learning, joint ownership with the perspective of humanity, and also a long term, that something that we have to achieve. And also it's good that we have this active listening practices, respecting each other, and then not always dominating, but on the other hand, we also voice our our concern. So it's a balance between we want to voice our concern and also not dominating the dialogue. So if we can have those things, then, and if we can develop a good team, then we can have the team can have these attributes. First, it has a focus, right? So usually a good team, we have a common goals, common program, also shared interest, shared vision. It also has and also agree on set of values, right? For example, can be values on culture, on social norms, trust. It can also have identify benefits of those collaborations. They know that what kind of capacity the other team members has and contribute to the team. They respect different capacities and sharing resources, and also have this equity principle, like a reciprocal, mutually beneficial, and there is a experience knowledge exchange within that, and it has a good communication within the team. So the communication will be transparent. You have gained trust. You can speak openly, honest, in consistent and effective dialogue. So you can feel those when you have a strong team, and it has a leadership in it. I think we know that who's doing what and when, and who's lead those activities and those things. And if there is if there is any conflicting issues, there's a way and mechanism to solve those issues. So there's a what you call conflict resolution mechanism, or even consensus how to solve those issues. So if we can achieve this, then we developing a good IR team. So that's, I think, things that I want to recap for those team building, because then it's the first step for you in the journey to have a sustainability project in implementation research. Any questions, comments? Yes, Maria.
So just to understand, so you start with the stakeholders, right?
Yeah.
So when, because, for example, for yesterday we did this is what we need to do, right? The work breakdown structure, and then you know, okay, who should allocate to what, right? So here, do you start with the stakeholders and then define the question? Because I'm just trying to see when they are, for example, our participants or our members of the team, thinking on the implementers of the program, because there might be cases when they are our study participants.
So I think this is where this dialogue happens. It identifies problems. It identifies the resources, who have those resources, and whether we need that to implement, we need that to consult, we need that for other purposes. So when we have those identify problems, common problems, and identify what kind of resources we need, then that's when we can somewhat, see what kind of teams we need, what kind the teams we have to develop, and then we make those breakdown structures. So that's my experience, but perhaps other has different experience when we develop those things. Dorothy, you have other experience?
I think similar kind of thing. The first is the stakeholders and getting everybody together on board, and then you do the allocation of tasks and the actual work breakdown structure.
Yeah. Okay, any other questions?
I just have questions on the ownership. Sometimes if you're working with a particular intervention, you're working with stakeholders which have already a set of objectives and things with them. So what are ways to be able to also share the ownership with the stakeholders?
Okay, so I think a good start that we also map those stakeholders. What are their capacity? What are their interests? Would it be something that beneficial to the project? Would it be in conflict with? How can they be of influence to the project? So if we can have those maps, then we can easily see how to interact with them. Whether we need to just inform, or we need them to consult, or we need them in our team to implement. So those, if we have those maps, then it's easier. Please, Franklin.
Yes, I was just thinking, assuming that you intend to include some implementers, and somehow they decline to be part of your team, what happens?
Sorry?
What happens if they decline?
If they decline?
Your team, yes.
That happens to our project also. Then we need to understand why they decline, and then see how can at least not at least, but we can have others implementers as our team, but at least they're not opposing our project, at least. But you can also approach others. I mean, you can investigate who is in their circle of influence and try to advocate to those, try to influence this. So it's like we create a coalition so that it can have influence those stakeholders. It's a way of influencing others. Jordi has a lot of experience with this. Jordi, you want to share? No? No, I mean, now you have a lot of experience engaging implementers. Sometimes they refuse to collaborate with project, and then how we engage them in the end. And Jordi has a lot of with the high level stakeholders.
Okay, the other issue is that we should not see this as just a one-off for this particular project. You need to build this based on a long-term relationship. I mean, if you just see it as a one-off project, it's a bit more difficult. But with the stakeholders in the country, what we do is we try to maintain relationships with the stakeholders, the different players, because if you just come in for one particular project, it's usually a bit tricky. But if you already have long-term relationship beforehand, also that's something you can build on. And usually also what we see is, that, for example, if you work for the Ministry of Health, it's not one single entity. There are units, there are people within the ministry, and sometimes they're not one voice also. Sometimes you can map out who agrees, who doesn't agree, and you can work out with people who are actually more supportive of you, and you can work out with those people, and they can help you to move things forward, even though at the beginning someone says no. I mean, here we have example, for example, the Ministry of Health says no, but the DG says yes. And we can still move forward even with that. Of course, not officially. But we have those kinds of experience. So the ministry is not one entity. I don't know in your setting, but in many settings it's like that. You can actually identify who is saying yes, who is saying no, and who has the influence, who has the power. And even though the ministry says no, if you have the right people, you can still progress. We have a lot of projects in Jogja which was cancelled by the minister, but then we continue polio, for example. The mosquito. The minister says definitely no, red light. But then we work out through the director, through the DG. It takes time, but at the end then it progresses, even though they don't acknowledge that they say yes, but they let it go anyway. So it's a matter of building relationships with a lot of people. Within the stakeholders, but it's also tricky in one hand that if you're too close, also there's a risk. Sometimes you lose your objectivity as a researcher because you're part of the system. If you're too far, it's too difficult for you to work. So you have to be somewhere in between. We have that problem also. At one era, we're very far from the ministry. They despise us. They say, don't work with these guys. At some era, they say they love us so much because people change in the ministry. Yeah. There's a huge turnover in most of our countries, right? They keep changing also, and it's just we have to do it over and over again. But don't just see it as for one particular project, but that we really want to work with them through different issues, different things, so that they just don't see us as opportunistic. Okay, these guys are just scientists. They just want to do this opportunity for their own benefit. But if they see that we are sincere, it helps. And if you have a relationship in place, that's just my...
Thank you, Jordi. You really touched a very important issue. So it's not only one thing, but also this building relationship and trust is a long-term issue. Thank you. So any other burning question? Otherwise, because it's already 4:05, then I will stop. And what is the next exercise? Reporting and dissemination. Okay. So you will have that for about until we'll close at 5. Okay. So that's That's the maximum. And then we will have the presentation tomorrow morning. So work on that and see you tomorrow morning. Thank you very much. Don't work more than 5.